Yes, ma'am. Doing the same. You can go now. You can start the session now. Thank you. Madam, please start.
Okay, thank you. Um, 2.5-year-old female child, first by birth order, born out of non-consanguineous marriage, resident of Diva, hailing from UP, brought by parents, informant being mother, came with complaints of fever since 1 week, cough since 1 week, cold since 1 week, and paucity of movements in right and left, right, right upper limb and right lower limb since 2 days. History of present illness. Fever was undocumented, moderate to high grade, intermittent, relieved on medication, and child used to be active in interfebrile period. Cough was dry in nature, non-spasmodic. Mother noticed paucity of movements after waking up from the sleep in the morning while changing clothes of the child. She noticed that child was not able to lift her arm and not able to hold cup. And she also noticed that child was walking with dragging right leg. This gradually progressed and child was not able to walk or stand on her own next day morning. On further inquiry, mother also told about deviation of angle of mouth to right side, noticed while crying. Complaint of inability to speak was also present. History of altered sensorium present in form of irritability and altered awareness. No history of involuntary movements. No history of any other cranial nerve involvement. No history of inability to turn to one side or lifting head from waking up. No history of swaying while walking, tremors, involuntary eye movements. No history of seizures. History of paleness of body present. History of blood transfusion present 10 months back when child was admitted for pneumonia. No history of vomiting or head banging. No history of trauma. No history of rash. No history of cox or cox contact. No history of bleeding from any side. No history of similar complaints in past. And no history of similar complaints in family. Antenatal history. Pregnancy was registered. 3 UHG scans were done, told to be normal. History of anemia in pregnancy present, for which iron transfusion was given at 20 weeks of gestation, and iron folic acid tablets were received. No history of gestational diabetes mellitus, hypertension, and hypothyroidism. Child was delivered preterm at 26 weeks of gestation in view of premature rupture of membranes. Child did cry immediately after birth, and birth weight was 1 kg, for which NICU stay was there for 1.5 months and required mechanical ventilation for 20 days. Child is immunized till date. Developmentally appropriate for age, and anthropometry wise underweight.
What was the weight?
8.5 kg, which is -2 to -3 standard deviation. Rest are in -1 to -2 standard deviation. This is the only child, no significant family history. Dietary history, child was breastfed and also top fed with cow's milk for 6 months till 6 months of age. After that, weaning food was started. Currently, child has calorie deficit of 650, 450 kilocalorie and protein deficit of only 1. So my summary is 2.5-year-old.
Later कर दो.
Sorry.
Later करो. So we've done this exercise many times. What is your analysis of the fever and cough? Then we'll come to the paucity of movements. What do you think of the fever and cough?
I think it is not related to the paucity of movements. It is because of the UITI component. The cold is also good.
Yeah, so fever cough you think is a
And incidental finding.
it's an incidental finding or not related to the subsequent events. Okay, so what do you think? It's a bacterial infection which has spread, viral infection? Okay, forget. Come to the paucity of movements. What do you think of this? Where is the anatomy of the problem? So the child woke up and the mother found that not able to lift her arm. Which arm? Right.
Right.
So right upper limb not able to lift and dragging right leg. So what do you think? Where is the anatomy? One.
Cortex,
One.
because there is a difficulty motion of the limbs and there is large area involved because arms and legs both are involved.
So if cortex large area is involved, then there should be a seizure, no? There was no seizure. So why do you think cortex is involved?
All the tracks passes through white matter and the nuclear present in gray matter. There is acute history, which is progressive in nature, gradually progressive in nature. Probably and there is altered sensorium also. And there is
Altered sensorium when this child got up in the morning.
when since last 2 months, yes, means the.
So see, this is a little important and you should learn to take this history very properly. So suppose altered sensorium was there even before the altered sensorium was there even before the paucity of movement the day prior, and that fever and altered sensorium totally change the thought process as to what happened later. When you gave the history, I thought that altered sensorium came up later because later you have said that this child was totally unable to walk. So there again we need a exact sequence of events. Here the child was dragging the leg and then whether the other side was affected or what exactly happened, we are not clear. So can you repeat exactly what happened?
After waking up from the sleep, mother noticed that there is right upper limb weakness and right lower limb weakness, and child was irritable at that time also. And gradually the weakness progressed, and the father next day noticed that the child is not able to walk at all. And day before that there was only upper limb more involvement, and the next day lower limb involvement was also involved.
So what increased was the severity of the weakness, but not new area was involved, no. Okay. So what I was trying to tell you is that for your reason of deciding cortex versus spinal cord, there are various things. So with cortex, you have associated change of sensorium, seizure, etc., aphasia. But also this kind of a distribution of one upper limb and one lower limb is next to impossible in a spinal cord. I mean, it is possible, but it is very uncommon that you get a hemiplegia due to a spinal cord lesion. Sudden, gradual, of course, you can have a SOL and you can compress and things like that, right? So you have to put all those 2, 3, 4 reasons one after another to say where is your anatomy. It is the cortex or the spinal cord, right?
Actually, considering fever and cough, you said dry cough, which means the upper airway. And you said also cold. So probably we'll call it a viral infection because there is a cold cough both. Okay. In a typical bacterial infection, you won't have cold. And if you have cold, then you won't have much of wet cough, yes, but not dry cough. So possibly this is a viral infection. Now, every symptom you must tell us the progress. If fever is for 7 days, we want to know how long did the fever last? Did it last for 7 days? If so, then why is this viral infection continuously having fever for 7 days? So get all these details because if do you think a viral infection can go on for fever for 7 days, or it should get over by day 3, day 4. In any form.
Viral fever does not extend for long duration. Generally means of by 3 to 4 days.
Would some viral infections continue fever for a long time? So we'll consider that. Because this did not look like a bacterial infection because there was also cold, also cough, also fever. So it was a generalized respiratory infection, so less likely bacterial. But as you said, within 3 4 days, most of them should get well. So the question is, which viral infection can go on for a longer time? And one of the common ones is an Epstein-Barr virus. Of course, CMV can go there. Okay. So it's not that viral infection should start. So could it be an EB virus coming up? If so, what other symptoms you expect out of an EB virus? That's the next step.
The virus generally immunocompromised patient and there is history of any recurrent infections, recurrent cough, cold, and the skin lesions.
EB virus will present with lymphadenopathy, cervical lymphadenopathy. It might be tender. Also, it might present with a gradual splenomegaly. Also, can develop pain in abdomen. Might occur.
That's one.
Good, but that's on examination. You're right. It's not that EB virus affects the immunocompromised patient. It affects the immunocompetent patient. But classical story is a mucosal inflammation. Okay, glossaritis. And of course, then on examination, you might see liver spleen, lymph nodes, etc. So again, at that stage, we could have asked, what more than colon? Did you have any? Because again, a fever that continues for a long time could be non-infective cause. And one of the common non-infective causes are immune mediated. So again, joint pains, again, glossitis, stomatitis. Okay. So we could have asked all those questions, but yes, this is just to teach you how in depth you can go on. And you can only ask these questions if you started thinking on the first statement of the history itself. So we presume now that there was nothing of that kind. If it was a viral infection, it would not have got worse unless it complicated. But there is no complication occurring so far in the first few days. So the question is the fever getting better? If it's getting better, then surely you are a viral infection. Let's believe it's a viral infection. Then whether the infection or the fever was continued when this second symptomatology came, or there was a clear interval between the two, which is important. Many times when immune-mediated disorders come when you are almost getting out of the previous infection, and then starts the complication. In dengue, it could happen typically in 1 or 2 days. The child may go into shock. In many situations, it could happen after a week, or in a rheumatic fever, even after 2 3 weeks. So, to that extent, we would like to know, was there a fever-free interval between? So that becomes important. Each one of these will give us an idea where we are. Then we come to this. There is some irritability. Okay. Again, sequence of events, what Dr. Chokali said, we would like to know whether before the weakness came up, was there some irritability or a drowsiness, which means that the encephalopathy is coming up. But again, we believe that there is some irritability. Again, irritability could be simply because he's not able to move his leg. So we need to ask more details. Was it manageable? Was it unusual? Okay, all that. And then once you consider encephalopathy or no encephalopathy, okay, the question is, this looks like a vascular event. Okay, now you want to think whether it's an arterial vascular event or a venous vascular event. Any idea how you differentiate the two? And one thing is that arterial almost have hardly any evidence of a drowsiness encephalopathy worsening. Venous, yes. And why is that so? Because in venous infarct, the rest of the venous drainage gets affected, so entire encephalon is involved. Here, entire encephalon is not involved. So many times there is no evidence of encephalopathy at all, only the weakness, depending on where the motor system is involved. So hardly any encephalopathy in a vascular involvement is typically an arterial. Whereas had it been change in sensorium, it would have been venous. So we come to a conclusion that mostly it is viral infection, but we would have been happy to get all these details. You're learning. So history taking is most difficult, and you need a lot of thinking, because unless you ask a question, the parents won't give the reply. Parents don't know what to say. They only say they have fever, they have cough. You need to ask many more questions. And therefore, let's believe it's a viral infection. Let's believe, therefore, it's some vascular element. And therefore, till proved otherwise, we will say this is just a complication vascular occurring. The question is, why is this complication occurring? We'll call it immune mediated. Okay, some vasculitis. Could it be thrombosis? One common cause is thrombosis. Is this child likely to have a risk of thrombotic event to come up? You have some other history.
History of blood transfusion is present, history of pain is. Iron deficiency anemia is a risk factor for thrombosis.
Excellent. Very good. And therefore, again, whenever you have a vascular event, thrombosis being most common, you need to look at whether the given patient is at risk of thrombosis. And one thing you said rightly is that why do you consider in history it's iron deficiency? Mother had iron deficiency maybe. But mother may have some other cause. You're right. Give me a thought. Argue in some way. Okay. Sometimes in arguments in examination, it's like a legal one. Both sides there are arguments, no? Both look like very, very positive. Age of the patient.
Anybody? Why, sir is asking, why do you think this is iron deficiency?
Age of presentation first. Age of presentation. 2.5-year-old child most probably will not have any other hematological condition. It should have presented before. And most common cause of anemia is iron deficiency anemia. And
Some other scientific reasons. Fold close like this, fold like this.
So at this age, the child is usually they shift to drinking cow's milk, and in some cases, excess cow's milk may lead to iron deficiency also in dietary issue.
What was the birth weight of this child?
1 kg.
Does that matter? With respect to iron deficiency?
There is no time for iron stores.
Okay. Now another question. This must be sickle cell anemia, no? That is why pallor, that's why needed transfusion, and now an infarct fits in with the sickle cell disease. So what are your thoughts for that or against that?
Pain crisis. Pain crisis will be there in sickle cell cause there will be history of consanguineous marriage. Organomegaly.
That's on examination.
So that endemic community area, geographical area, all that you will also consider, right? Yeah, you want.
Also, we will ask their family history if anybody has repeated blood transfusions or if anybody has undergone the gallbladder cholecystectomy at a young age or something like that.
Yeah, there was history of fear for 2-3 days. followed by some interval and then the event, or all the 7 days there was fever? To close.
According to mother, child was afebrile in between for 2 days.
This is again something which warns us. Fever, no fever, and late transfer. And in this, the fever is low grade, but really what puts you on guard is the behavior of the child. There can be a period of as much as 4, 5, 6 days where the child doesn't have fever, but he is not normal. A few days back, I saw a child with low grade fever. But she said that he's not as good. He was sometimes good, sometimes not good. He was not very good. I was not very comfortable. I did not see the child. Got a CRP, etc. done, everything normal. He threw a fit after 7 days. And it turned out to be chikungunya related encephalopathy. Now, that is not important, but that particular 7 days never made me happy. There would have been no clue that what is going to be. So when there is a prolonged history, then you are always guided by how the behavior of the child. And if the behavior is not good, you do anticipate some problem, usually neurology, some allergic encephalopathy. Now here, of course, there is a right side, and as we said, if involvement of one side is there, it cannot be a huge area from on the cortical side, and then the symmetry also will not be there. So it has to be where the tracts have come close together. So in a single small affection, many tracts are caught, and that will happen only in a internal capsule region where they are densely, so to say, together. So internal. But I don't know whether you said right side hemipen. Did you say the angle of the jaw was turned to the yeah, on the which side the angle turned?
Right.
So the angle went to right side, and the hemiplegia was also right side. The angle went to the right side, that means left side was paralyzed, and he had right-sided hemiparesis and left-sided facial. So this was a cross hemiplegia. That brings down the localization further.
So, no. So first step is, are you sure it is crossed or it is a mistake? Always ask yourself, because crossed is uncommon. And if you are sure it is crossed, then the next discussion.
On examination.
So it is crossed. Okay. Now the next
So
discussion.
cross means further limitations, and you have different syndromes of cross, and for the third nerve and cross hemiplegia Weber's. So in the third nerve area, 6, 7 is lower down, and therefore you are narrowed down to a lesion.
But now is it internal capsule now? If it is crossed hemiplegia, where is the lesion?
Where is the facial nerve? Like
So pons medulla
Yeah.
somewhere there,
Lower.
but not internal capsule. So you have shifted now. Cortex is gone, internal capsule is gone. Now you are pons and medulla.
And then the lower the lesion, I don't expect that everything will be affected to the same extent. The tracts are not so closely, densely placed. So some area of the body or the right side is likely to be affected more than that, as against in the internal capsule where the affection may be more. Then coming to the etiology, as Sir said, usually a vascular lesion, and whether it is arterial or venous, as he had pointed out, that venous means it's a venous sinus thrombosis. Oh, entire big area of the cerebrum is gone. And the distribution tells you whether this is arterial or no. Because the hemiplegia will occur in the distribution of blood supply to that area. That is why you have typical patterns of hemiplegia. So, therefore, with this distribution, you will say that it is likely to be the distribution of one vessel, and therefore arterial, and therefore more likely to be thrombotic, and very nicely told by the, and incidentally, of course, we are not come to the physical examination. 1 kg child and head circumference is absolutely normal of this particular child. So that's very good, makes me happy, but otherwise also. So anemia, hemorrhage, less likely, and hemorrhage, the so to say, presentation will be more devastating. While thrombosis may not be. Embolism, yes, only if there is a proneness to embolism. Otherwise, we don't take him. So acute event, slowly progressive in the distribution of a blood vessel, namely artery, and relatively localized, and preceded by something which you could not. 2 days fever, 3 days fever, everybody could explain why the child was not well for next 3 days. Maybe fever wise he was all right, but therefore, दिन अच्छा था, एकदम अच्छा था, खेला. No, it was low. रो रहा था, खेलता नहीं था, बैठा हुआ था. So something was cooking inside, which presented abruptly after some time. So I think for every case that we see, somebody is brought for fever, etc., and there has been some. All ask you if the patient is going on for fever for 5-6 days, you are not comfortable. Something low grade fever, the behavior of the child is not good, you are anticipating some problem somewhere, maybe immunological or complication. This is exactly what happened to this child.
What about inability to
Ah,
speak?
complete.
Where is the anatomy? Broca's area?
So first, whenever you give such a history of inability to speak, you have to be again dig more into the history. What do you exactly mean by that?
For the last 2 days, child was not able to speak at all. There was no verbal output. And child is preferring right, normally right-handed. But child was not speaking, so probably dominant lobe involvement.
So now where is the lesion?
Or- So if it's upper motor neuron palsy, then there will be a bit contralateral involvement of facial nerve.
Yes, but not at the internal caps.
The Broca's area is rarely involved clinically. And the reason is many other centers can almost take over the function of Broca's. Not that it cannot. Therefore, most of the vascular events with hemiparesis, speech is not a problem. So if you say that he is not able to just put up any word, then possibly is it something central? Again, we are now from a localized lesion quitting to a separate another lesion, unrelated, or whether there is any lower down problem with my vocal cords. Do you think that's the reason why I can't speak? Okay. Or to able to speak, I must have a good respiratory function. So is this child having any paresis or any respiratory muscle weakness? If so, then is it all lower motor neuron? So good to discuss inability to speak. Give us a try, doesn't matter.
Because if we are considering a lower involvement, suppose pons or medulla involvement, so the 10th nerve can be involved in that, like a bulbar palsy or something, the laryngeal muscles can be affected. Maybe that is why the patient is unable to.
Good. So now what additional history you will ask around that? Good thinking. So now around that, what history do you want to know?
Inability to swallow.
So regurgitation, trickling, difficulty in swallowing, is it there? No, it's not there. Okay.
And when there is no voice, that means the vocal cords are not moving. Okay. If they are not moving, are they in an adducted position or abducted? If they are in an abducted position, there is no voice. If they are in an adducted position, there is no breathing probably.
मेरे जोशी सर बच्चे में बैठ के क्या करें?
We asked at that point to really realize where the thing. So it's a bit of surprising. I may have expected that he is not able to speak clearly. Okay, then it's fine. So suppose we take for granted he is able to put up words, but we can't understand what he's saying. That means there is some problem peripherally. Does it mean that the 12th nerve is involved? We are across my hemiplacia, no? Do you think a 12th nerve involved, the child has a problem of speaking? Or any other cranial nerve involved where the problem is of speaking?
So what happens if because of 12th nerve, the child doesn't speak? Is what is the difference between that not speaking and aphasia? What is the difference?
Aphasia will have no sound coming out only, but Vesna will have certain muffled sounds coming out. You will not be able to articulate the speech properly with that way.
Very good. So 12th now will lead to lack of clarity, but there will be sound, right? And it will be again intelligible, as in the patient is trying to speak sense only, but you will not be able to hear it clearly. There will be lack of clarity. Her words were no word output. So that means aphasia if there is no word output, right? So now you have to ask on history, okay, what happened if parents gave him instructions? Was he able to understand those instructions? That means receptive speech was normal, but not able to answer back. So no expressive speech. That would localize it to motor aphasia clinically, right? So you need to ask all.
Or whether his sensorium was affected and therefore he was not able to reply. There was nothing wrong with the speech and all, but he was not in a position from which he recovered over a period of time.
Even the seventh nerve involvement also, there is no clarity of speech. You see how Mr. Sharad speaks? Okay, he has one cranial nerve gone. So, but there is speech all right, but it's not clear. So if this is so, then we go right up to the center. So then there are two different areas, or you are right that occasionally in a hemiplegia, Broca's area also could be involved. But this is not common at all. So let's see on examination where we are and all that, right? Last question I have is, mother required transfusion, no, during pregnancy? Iron deficiency, but transfusion.
Iron transfusion,
Iron,
IV
doesn't
iron,
matter,
yeah.
iron transfusion. So, do you think an iron deficient mother during pregnancy passes on iron deficiency to the baby, which adds on to this premature baby? What's your comment on that? Many of our mothers are iron deficient. Okay, but this mother must be severely iron deficient to get iron infusion. Okay, there must be some reason for iron infusion, right? I think which must have been given because they wanted to bring up hemoglobin first. Do you think IV iron brings up hemoglobin first? I know IV antibiotic works first. I know IV sedation works first. Why should IV iron not work?
The rise in hemoglobin is same with IV and oral iron.
So IV iron will not change the.
So then why is IV iron given?
Mother is saying that HB was 5.5, very low hemoglobin. That's why IV iron was given.
Correct. So now we are asking you, suppose hemoglobin was 5, is that reason to give IV iron? Will it come up faster? You just said no. So then why IV iron was given, or when will you give IV iron?
In fact, you have rarely.
Should not be able to absorb oral IVI.
Okay. But with iron deficiency, the absorption is faster and better.
So you're right, theoretically, any kind of malabsorption, but for that you need to know that this patient has iron malabsorption or generalized malabsorption to take that step. So in pregnancy, possibly it was given for tolerance issues, that the mother may not be able to tolerate oral iron daily. Already there is a vomiting of pregnancy, this, that. So to ensure that let the iron go in, it was given IV. You get my point?
And compliance. All advice given, but mother was not compliant, took it for some time, and if she's non-compliant, unnecessarily she's going to land up with iron deficiency. And answering the question, mother is severely iron deficient. Is the baby pale at birth?
Sir, ask you that.
We were told that the mother may be really very severe, but the baby is pink as ever.
So in other words, babies not stores, but babies quantity of various nutrients, be it iron, be it calcium, be it whatever, is it directly proportional to mother's stores? Does a malnourished mother give rise to a malnourished baby? Okay. So now the concept you must remember is that the baby always get a priority at the cost of mother's health. In general, for all nutrients, it is not a equal to relationship, but it will always be a priority. So here, as we said, in the third trimester, all the stores go to the baby, and this baby was born low birth weight, premature, whatever. So that reason stores may have been less in the baby, but not because mother was deficient that baby is deficient. Okay.
And also hemoglobin may be good, but the source will not be adequate. So the fall of hemoglobin which will start after 6 months or so, in this baby it will because she is born with low storage. The hemoglobin or the color may look pink. So they have deprivation of storage. If somebody's hemoglobin falls by 1 gram, that means the stores are already depleted. Without that, the hemoglobin doesn't start falling.
Now-
There are two issues. One, if a child is malnourished, same thing as what mother could be malnourished, but particularly child, because he is yet to grow, so his malnutrition is going to have a much more impact. Would you give a blood transfusion to a severely malnourished? Each fail. What's your comment? Is it safe? Is it not safe? On one hand, you want to build up the hemoglobin to a safe level. On the other hand, is severe malnutrition a contraindication? And the answer is yes. Because many times there could be an immune reactions to minor blood groups, etc. Plus the volume itself, you have to give it very slowly because there could be a problem of running fast and the heart is also not strong. So just keep that in mind that malnourished child may not have a priority for giving a blood transfusion. You might have to build up the volume first a little, push some saline, and thereafter give it very slowly, and all that becomes important. Otherwise, we have said that now he said that in the last trimester, most of the nutrition goes to the fetus, and if that he has missed, then he's deficient. Is it true for thyroid also? So there's a hypothyroid mother passes on the menu. Then thyroid is an exception.
Thyroid hormones are not transferred via placenta. Child is not dependent for thyroid hormones on mother.
Very good. So what she's saying is the fetal thyroid starts working by second trimester, and only in the first trimester the fetus is dependent on mother, but not thereafter. Right? Good.
But I saw a baby of a hypothyroid mother, the baby was also hypothyroid. The antibody mediated hypothyroidism may come little later, but this was hypothyroid earlier at birth. They were staying in Himachal Pradesh area.
Iron deficient.
That will, mother is iron deficient, so she will not give iron to the baby. Baby is hypothyroid because of iron deficiency.
But I must have told you this. About 3 months ago, I saw a family who had come from UK permanently to settle. And within a short time, they said that, no, I think she's very lethargic. She doesn't want to be active. Initially, they thought change because she was about 7-8 years old. So change from UK to here, it must have disturbed her. But when I looked at her, even there was a bradycardia. So she was hypothyroid. Now, the initial state, they must have done a cord blood levels, the intelligence was fine, growth is fine. Then I said the only way is an iodine deficiency. But I told the parent, I think everybody in the world now takes iodine salad. They said, no, in Britain we don't take iodine. I was most surprised. Now I know that how India has really gone ahead of all the other parts of that. Really. I mean, I was surprised. I was not ready to accept. He said, no, sir, I'm very sure. Then I said, let's do that. So start your regular iodine salt. And 3 months down the line, TSH is coming down. She is, the moment she takes that, she is active. So iodine deficiency, in fact, I remember when I was an examiner, one of the examiners was fond of asking, suppose which deficiency nutritional is important for the security of the country. What is that to do? We said, no, our soldiers are fighting there, no? They don't get iodine. No, that is too much to. But the point is, iodine deficiency is a known feature.
And one word, what is the fashion these days? What kind of salt we want to eat? Pink salt does not have iodine. Just remember that. So all fashions are not necessarily good. So if you are taking pink salt, white is better than pink.
Okay, now this, look at the growth and someone comment on the growth.
That's right.
So is this baby premature or was this baby IUG or both? That is one question, and now talk about the growth.
Child was premature, delivered at 26 weeks of gestation. And growth was good for the birth weight of 1 kg.
So for 26-week gestation, is 1 kg IUGR or okay? You should know all this, huh? This is very important. Okay, now talk about this. Growth is okay, you said is fine, but talk specifically. What about weight? What about height? What about head circumference?
Weight is 8.5 kg, which is -2 to -3 standard deviation. Weight is compromised. Child
No,
is
for the
underfed.
baby was 1 kg. Interpret that way. This is meant for everybody.
Child should catch up by 1 year of age.
But how far will 1 kg come up? Don't know. 1 kg may become 6.5 by 1 year. Increase 6 times, let's say 5 to 6 times. And 6.57, then 8.5 may be malnutrition little later. Not too bad though.
Height is normal, 85 centimeters, which is -1 to -1 standard deviation.
Actually, fantastic height for a 1 kg
So
baby.
what does that one observation rule out? That single observation of height being near normal, what does it rule out in pregnancy that it was not this? Symmetric IUGR is ruled out. Okay.
Head circumference is 44 centimeters, which is -1 to -2 division, normal for a case. Weight for height is between -2 to -1 standard deviation, and mid upper arm circumference is also normal, 14 centimeters, between -2 to -1 standard deviation. So only parameter compromise is weight, which is 8.5 kg, which is also good for the child, considering the birth weight was 1 kg.
What must have been the head circumference of this baby at birth? Because it means that today's 44 is not bad. Like today's 85 is not bad.
Very good, sir.
Yeah.
Very.
So what must be what is the normal increase in head circumference? 2-year-old, eh?
Yeah, 12.
2.5.
1.5.
2.5.
12.
Yeah. So how much is the head circumference centimeter increase?
In a normal baby, what is head circumference at birth and at 1 year? So how much does it increase in the first year? That is what sir is asking.
Normally it is 35 to 36 centimeter at birth. First 3 months it increases by 2 centimeter per month. In next 3 months, 1 centimeter per month, and after that, 0.5 centimeter per month for first 1 month.
So 10 plus, right? Yeah.
So total 10 to 12 centimeters in the first year.
So this was 44. So what it must have been?
And this is at 2.5 years. In the second year, it increases by normally. Normally, head circumference in the second year, from 1 year to 2 years, increases by 2 centimeters, 2.5. Okay. So you have to go backwards by 12 to 14 centimeters in this
So
case.
30 to 32. Now, what is the average head circumference of 30 to 32? What gestational age? And the answer is simple, 30 weeks to 32 weeks. At 28 weeks, 28. Okay. So this must have been some way small nutritional problem to begin with. That's what we are now seeing. And therefore, even that is quite consistent with the baby was a bit malnourished, not severely, obviously not symmetrical. And therefore, even today, you see everything that is, you can even derive what the baby must have been at the. Okay. I think this case is not very difficult to go. So in an examination, they would ask only on this. Okay, especially if you're going to pass, definitely they want to find out what more do you want. So learn all this. That is the reason why we want to impress on this, not just the diagnosis. Many times nephrotic syndrome is straightforward. The most difficult is the question that going to ask. So you learn how you could do that.
The last word here is impression underweight. I thought it was impressive underweight because they're really impressed by the weight the baby has gained.
So summary, 2.5-year-old female child with complaints of fever since 1 week and paucity of movement in right upper limb and lower limb since 2 days, with right upper motor neuron facial palsy, with aphasia, with altered sensorium, with anemia, with significant NICU stay, in a developmental normal child fully immunized, is probably a case of acute ischemic stroke, probably due to arterial thromboembolism.
Thromboembolism are 2 words.
You look at the baby.
Here you have said right UMN,
Yeah.
right hemiplegia and right UMN. So all this will
Is it
get it
across or
confused.
That was my doubt, right? Upper motor neuron palsy will cause contralateral facial palsy.
So we'll
Because
X it out.
Only by person, who does. That's only for up to like a like what you said, you to the right side, then the paralyzed side is like this. Which one? That's something. एक मिनट को उधर कैमरा उधर है ना इसलिए और बाहर के लोग भी देख रहे हैं ओके हाँ
क्या नाम है इसका?
Arya.
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 child is
Hello, Arya. I see it.
sleeping comfortable in mother's lap. No, well nourished.
It's 2.5.
2.5.
What is his environmental reactions?
Child is irritable. Conscious, irritable.
You can add whatever.
I think what attracts you is he's not much wanting to respond to environment. Okay, he's not lethargic, but he seems to be just not interested. Okay, so there is some behavioral disturbance, definitely, whether it's due to the disease or due to that. Even a severe protein malnutrition does that. Okay. Why? Because there is an encephalopathy. So make a note of that. He's not crying, he's not irritable, but he's not interested at all. That's some behavior change, right?
The child is able to move left hand but not moving right. Yeah. What that's moving.
What else?
Family is there.
What else?
Is he on steroids? Look at his cheeks. Oh, his cheeks are like
What else?
Child is looking well nourished. It's a well nourished child.
So, since you have just given all the parameters, the word well nourished will invite trouble. So you say the child is normally nourished or there is enough subcutaneous fat or something. That is what you have to say.
Child is normally nourished. With no visible muscle wasting or atrophy. Child is not moving right upper limb and lower limb. Child is moving left upper limb and lower limb.
What about the face? Anything can be seen?
Child is able to close the eyes.
Oh, yeah, that's good. We are happy. That means he's responding.
Child is able to close the eyes. There is no obvious deviation.
Nasolabial folds are also appreciated bilaterally.
So just now, if they are appreciated bilaterally, what it means is that the facial is already recovering. Okay. Now let's sort that confusion about crossed and all. So when you have the face angle of the mouth pulled to one side, whichever, let's say it is pulled to the left side. It means what?
Right side. Right side facial weakness.
Correct. Right-sided nerve weakness. So left side is normal, right is paralyzed. So the normal side pulls it to the normal side, right? So don't get mixed up with crossed paralysis because as we were discussing on history, crossed paralysis is very selective and the lesion has to be at a point where the pyramidal tracts have crossed, just crossed, right?
Just at this point of time, the first sentence, the first statement is right, that if a left is paralyzed, the face is turned to the right. Could the left-sided paralysis give you a left-sided extreme change and the right side looks better? And that happens in an extreme stage in a lower motor neuron lesion. When the atrophy occurs, then the side which is paralyzed seems to be drawn on that side. But that we almost would never see. So this is certainly that. So now that it is recovered quickly, again, that might tell us that it must have been an upper neuron that has recovered quickly, and therefore that must be on the same side. Okay. I think we'll not bother them a lot. It's a small child, irritable. Just show me the reflex. Because this is a good place to say, see the reflex. Use the stethoscope otherwise.
Currently also there is facial weakness.
Okay, there is a facial involvement. Okay, but we'll make him cry later. Just show the reflex first. Okay, you're right. If the facial is there, then we'll have to see. But we'll see the child crying later. Just stand on one side. Doesn't matter. Stand on this side. Fine. Yeah. Just see the facial.
Deviation to the right side.
your left is seen better. So we will have to check very, very closely. Obviously, there is no squint, right?
No.
So 6 and 7 is our, okay. And and the third is not. Third is also obviously not. But some fiber from the third could be involved. So
Almost equal.
looks like, okay, looks
Almost
like you're
equal,
finding.
sir.
Now, just the question is this unrelated to the thing? Have they noticed it before? There is a congenital condition. Okay, and therefore, one may have to look at that. Okay, what Meniere's syndrome?
Mobius syndrome and congenital absence of
Absence of.
absence of but in the absence of angular depressed muscle, this is pulled to one side, but the facial
folds are
folds
not.
not.
I think we will not
ठीक,
bother
चलो,
from that, because the child is very small.
कैसा है देखिए अभी?
ठीक हो जाएगा।
ऐसा है, रोते ही रहता है कि हमें इसके लिए रोता है,
चिढ़ रहा है, बहुत चिढ़ रहा है।
खेल रहा है, हंस भी रहा है, खेल रहा है, एकदम पहले जैसा हुआ है, रिएक्शन ब्रेन का, खेल रहा है, सबको देख रहा है, टाटा कर रहा है, ऐसे है कि ऐसा नहीं है।
कुछ नहीं सर, कुछ नहीं हुआ था, ये अचानक ऐसा हुआ है जो हुआ है, जो इलाज चल रहा है।
नहीं, वो साहब पूछ रहे हैं कि बीमारी से पहले जैसे सबसे बातचीत या जो करता था,
हंसता
सबसे
था।
हंसता था,
बहुत अच्छा था सर।
वो अभी वापस आया है कि नहीं आया?
अभी मतलब थोड़ा सा ना, तो जैसे ना उनका पैर हाथ दोनों मूविंग कर रहा है थोड़ा थोड़ा, और बोलने में भी थोड़ा सा, मतलब 1% आप समझ लीजिए, 1% जो है बात करने में, मतलब जैसे हम आप बात कर रहे हैं ना, कोशिश कर रहे हैं, लेकिन उनका जो लैंग्वेज है थोड़ा सा अलग है। रोने में जैसे बोलते ना वैसा कर रहे हैं, बिल्कुल बंद था जो। 1% आप पकड़ लीजिए, 1% चालू।
होएगा धीरे धीरे, फर्क पड़ेगा। थैंक यू।
पहले से काफी अच्छा है ना।
हाँ बिल्कुल, रिलीज है तभी अच्छा है।
थैंक यू। आइए आप इधर आइए। Examination quickly.
On arrival to ward, child was afebrile, irritable, heart rate of 110 per minute, respiratory rate of 22 per minute, saturation maintained, extremities warm, pallor was present, no neurocutaneous markers. Head to toe examination was normal. On systemic examination, central nervous system, child was conscious, irritable. On cranial nerve examination, first nerve could not be assessed. Second nerve, direct and congenital right reflex present. Third, fourth, and sixth nerve moving both eyes in all four directions. Fifth nerve, corneal and conjunctival reflex present. Seventh nerve, deviation of angular move to the right side was present on arrival. Prominent right side nasolabial folds present, and left side nasolabial folds were not appreciable on arrival. Wrinkling over forehead was present. Child was able to close eyes. 8 now, no difficulty in hearing. 9th and 10 now, gag reflex was present. 12th now, tongue movements were present. Motor system, bulk of muscle bilaterally symmetrical, no atrophy or wasting visible. Tone was decreased in right upper limb and lower limb, and tone was normal in left upper limb and lower limb. Power was decreased in right upper limb, it was 2/5, and left upper limb more than 3/5. Reflexes, superficial reflexes were normal, and deep reflexes, right knee and ankle were brisk, rest reflexes were normal. And neck rigidity, on arrival, child had neck rigidity, but no other kernix or bruisings. He was not, no other signs of meningitis, no signs of raised ICT, and sustained right side clonus was present on arrival. For abdomen examination, soft, non-tender hepatomegaly was present of 2 centimeter below right costal margin, soft, smooth surface, span of 8 centimeter, left lobe was not palpable, spleen not palpable, rest system within normal limit. 2.5-year-old female child with right-sided hemiparesis, with right upper motor neuron facial palsy, with aphasia, with altered sensorium, with anemia, with hepatomegaly, with significant NICUSA and develop in a developmentally normal child fully immunized is probably a case of acute ischemic stroke secondary to arterial thromboembolism versus biomeningitis because neck rigidity and signs of other signs, neck rigidity was present and altered sensorium was present. So for this, investigations were done. HB was 8.4, hematocrit of 29.
You said neck rigidity was present on examination.
On arrival was present.
And what else you said? Something else just now?
Reflex, altered sensorium. Altered sensorium and reflexes were brisk on arrival.
Okay, go on.
HB of 8.4, hematocrit of 29, WBC 8,200, platelets were 7 lakhs, MCV of 59, MCH of 18, and MCHC of 28. PT was prothrombin time was 16 and INR of 1.4, APDT of 24.7, and fibrinogen of 120. 350. Fibrinogen was 350. It was written wrong. CSF routine examination was done. It had cells of 27 cells, polym of 24 and lympho 3, and sugars were 75 with corresponding HGT of 120. This is CT brain was done with CT angio. This is CT angio video. This is the report. CT brain showed acute to subacute infarct in left frontoparietal temporal lobe with left gangliocapsular involvement with mass effect as described above. And few tiny hyperdense areas in left frontal cortical and subcortical region suggestive of hemorrhage. CT angio was suggestive of supralenoid segment of ICA do not show any opacification suggestive of complete thrombosis, and MCA is not opacified in its entire course suggestive of thrombosis, and multiple collaterals along the thrombosed M1, M2 and segments of MCA with puff of smoke appearance suggestive of Moyamoya syndrome secondary Moyamoya syndrome.
Read little too fast. Would you like to read little slowly?
CT brain shows acute to subacute infarct in left frontoparietal temporal lobe and left gangliocapsular area with mass effect as described. Few tiny hyperdense areas in left frontocortical and subcortical regions suggestive of hemorrhage. CT angio reveals the cervical part of ICA is mildly narrowed. Petrous, lacerum and cavernous part of ICA shows peripheral filling defect with intimomedial thickening. This may represent partial lumen occluding peripheral thrombus, possibly with vasculitis. Supraclinoid segment of ICA do not show any opacification suggestive of complete thrombosis. Non-opacification of A1 segment. Few collaterals are noted along the thrombosed A1 segment. MCA is not opacified in its entire course suggestive of thrombosis. Multiple collaterals along the thrombosed M1 and M2 segment of MCA with puff of smoke appearance. Sulcal spaces in left high frontoparietal and occipital regions are effaced and replaced with enhancing leptomeningeal thickening. Above features are suggestive of Moyamoya syndrome. And
So I think basically, see, we discussed whether it is cortex versus internal capsule versus there was some confusion about the facial. So today we are not able to sort of really see because the facial has almost recovered. But if there was genuinely, first we have to decide whether there was a left-sided facial palsy or right. Right-sided facial palsy plus right hemiparesis goes hand in hand, and there was that big infarct to explain that. If there was a left-sided facial, then it is a different anatomical area, which would mean a separate infarct, which may be the only clinical suggestion of multiple infarcts, bringing in a concept of moya that multiple areas there is vascular problem. Otherwise, clinically, we had a vascular problem in one big area, and that irritability and lack of sensorium, change of sensorium, and that this thing, aphasia also kind of fits in with that, right? It is one big central cortical area due to a vascular event.
I think whenever things don't fit in, the question is there are different lesions or it's some syndromic issue. Okay, and the latest IP, which had just come yesterday, it talks about a B12 deficiency anemia in a child who has a persistent proteinuria. I was wondering how you connect the two. And they said, no, this is some syndrome where B12 deficiency anemia is associated with that. So I feel now wherever there is such an issue, we know that one part may be some different illness than another, and one part must be acquired recently, another one pre-existing. And then we call it a syndrome. After all, what is a syndrome? A combination of few things which are commonly seen together or known to seen together. So I suppose that is the way we would talk about, and therefore some name given to that syndrome would be the best. But here the message is clear. Your findings given were right, but it was not congruent with what we expected. And therefore, at such a time, we would have to say to in an examination that I cannot explain that, but if I have to think which way it may be possible, then you talk about two different lesions of two different etiologies, one pre-existing congenital, another acquired. And I remember the days when we were being trained 6 decades ago, polio was not rare. And TB meningitis also was not rare. Both were common. And I've seen 2, 3 children who had polio and then they developed TB meningitis. And when such a patient came, one side was lower motor neuron paralysis, some other side was upper motor neuron paralysis, hydrocephalus. We did not know how to. We said, looks like TBM, but why one side is atrophied and low motor neuron? Could it be TB doing? No, it was two different illnesses. So I suppose that was two acquired different illnesses at different times. Whereas here, we could say one was pre-existing, another developed like this. This is the only best way we can go by. But good, this case taught us how some incongruent findings still exist correctly. Okay, and if you get such a child in an examination, the examiner might say, no, I don't agree with your finding, just to see whether you are right or wrong. And she would have said confidently, she was confident, no, it's on that side only. I think that's the only way we go by that, right?
And we should know the areas involved concerned with each arterial. Now here, mid-cerebral, we think middle cerebral must be localized part, etc. Such an extensive one. Frontotemporal parietal, 70-80% of the brain is involved with one artery. So we must revise our knowledge about the arterial supply. I thought with middle cerebral, it will come to this particular point.
It's full artery is blocked. There is nothing in the artery, full blocked.
But I think in neurology, this is not rare that the imaging findings do not correlate well with clinical findings. And the reason is the clinical finding is what you see today. And the imaging findings tell us what really existed even few days earlier, which clinician feels some of it is already getting better, like facial seems to be improving, but the lesion would still be seen on imaging. And I think to that extent, like you bump your head, okay, the swelling comes and the pain disappears after some time, but the swelling remains. Now, if I show you that child with a swelling, which is painless, then you say trauma is rolled out. Okay. And then you say, could it be a lipoma, fibroma, whatever? So I suppose many times Dr. Udani has said that two things don't correlate, and I think this was a similar example.
Also, the clinical symptoms or signs will depend upon the area involved has any signs present. For example, when frontal area is involved, you may not clinically get signs, you may get signs only pertaining to the involvement of the middle cerebral artery. The frontal area, the concept, the temporal area, some parietal area, they may not be clinically elicitable, especially in such a small child. And therefore, always I think the MRI shows much, much more than what we clinically think it is.
Done, no?
Also, this particular child's platelet count is 7 lakhs. If this child came to you before he had any event, including paralysis or something, and you did a CBC just like that, and you got a count of 7 lakhs, would you have done something or would you have not done something?
And deficiency has thrombocytopenia.
Yeah. So would you treat 7 lakhs? Shall I put him on aspirin for some time? Maybe I would have prevented the thrombosis by giving my 7 lakhs is prone to thrombosis. No?
Okay. So we stop here. Today we have only one case. We don't have a second case, right? Yeah. So anything from the online audience? Any comments? Any questions?
Thank you, wonderful case. I mean, we thought it was a dense hemiplegia, but it turned out to be a different, finally, the thing. Yeah.
Yeah.
Yeah, that is, yeah, the thing. Thank you. It was wonderful learning. Good learning. Thank you.
Sure. Thank you. So we close for today. Thank you very much. Thank you. Bye.